Once you're done with the lab investigations and you have a differential diagnosis now at your hand, which is basically relating to the lab investigations, the overall history, and the overall clinical picture as well. So what differentials you can have when you have these patients who are suffering from memory loss, and you want to have a clear picture what disease we are dealing in with, and apart from dementia, what are the other differentials that you can have on your list. So Alzheimer's disease is one of the kinds of dementia, and the very first symptoms over here are the memory loss. There is going to be an episodic memory loss in patients of Alzheimer's disease, which is very specific for these patients. Patients are also going to be suffering from irritability, anxiety, and depression. So these are going to be the associated signs and symptoms. Initially, there are no neurological deficits, and the patient has normal reflexes, and all of the neurological examination is basically uncommentable. Then we have the entorhinal cortex, and we have the hippocampal atrophy. So these are the first signs that the patient is going to exhibit when you're going to carry out the imaging in these patients of Alzheimer's disease. In contrast, when we have the frontotemporal dementia, that means basically the frontal lobe and the temporal lobes are affected, and it is going to basically affect the overall personality, as well as the memory loss is quite significant in these cases. Usually the first symptoms over here are apathy. Frontal executive of languages are affected. The patient is exhibiting disinhibition, overreacting, and compulsivity. They may have vertical gaze palsy, axial rigidity. That means that the trunk is involved in the rigidity and the limbs are spared. Dystonia is one of the features in which the overall tone of the muscles is affected. And then we have a condition which is known as alien hand, in which sometimes there is a constant posture that is maintained by one of the hands. So the imaging would be done, and we'd have the frontal, insular, temporal atrophy, and usually spares the posterior parietal lobes. Then we have another variant which is known as the Creutzfeldt-Jakob disease. Patients usually suffer from dementia, mood disorders, anxiety, as well as movement disorders. The mental status is quite variable. Patients have frontal focal cortical memory loss. They may have episodes of depression, anxiety, psychosis in some patients. Neurological examination reveals a myoclonus, rigidity, and Parkinsonism-like features. Cortical ribbing and basal ganglia are sometimes involved, as well as thalamus hyperintensivity on diffusion. So these are the features which are noted down on imaging techniques. Now we have the Lewy body disease, which is another variant, and again the patient is going to have memory loss as well as visual impairments. The first symptoms would be the visual hallucinations. RAM sleep behavior disorder is noted down, delirium, and we have the Capgras syndrome, which basically encompasses the attention deficit disorder, as well as dreams are quite repetitive in nature. And then we have the mental status, which is showing or drawing towards the frontal lobe, spares the memory, delirium is more prone. Visual hallucinations, depression, sleep disorder, and delusions are seen. Parkinsonism is usually observed in these patients, and on imaging, you would be looking for the posterior parietal atrophy. Hippocampi are larger as compared to the Alzheimer's disease. Vascular accidents can be one of the causative factors. So often they do not always occur suddenly. They are variable, apathic conditions. Falls is one of the history that the patient would be giving. Focal weaknesses are seen. Mental stasises show the frontal cognitive slowing, and they can spare the memory. Apathy, delusion, and anxiety is noted down. Usually, motor slowing spasticity can also be seen normally in these patients. Imaging would relate to the cortical or subcortical infarctions. Confluent white matter disease can be usually observed in cases of the imaging techniques. So all of these range of diseases you have to keep in mind, and you have to basically look for the signs and symptoms as well as relate them to the results of the imaging techniques, just to have exact or a definitive diagnosis in these cases of memory loss.